So, good morning, respected dignitaries, faculties, and my colleagues. I'll be talking about the extent of lymphadenectomy in radical cystectomy done in patients of muscle invasive bladder cancer. I have nothing to disclose. Half a century back, the standard treatment for bladder cancer was proposed to be a radical cystectomy by this case series published by Ledbetter and Cooper. When we talk about radical cystectomy, we also talk about doing a lymph node dissection. The various questions with which we'll deal this topic are as follows. Do we need to skip lymph node dissection during radical cystectomy? Can that be done? What is the best yardstick to denote the adequate pelvic lymph node dissection? Lymph node yield, lymph node density, various anatomical lymph node templates. Are there any randomized data to support this theory? And does the approach matter, whether open, lap, or robotic? And what are the lacunas? The lymph node metastasis is seen in roughly around 18 to 30% of the RC specimens. The incidence is up to 5% in T1 disease, around 25% in T2 disease, and 40 to 45% in T3 and T4 disease. Lesner et al. Had divided the template into 3 levels: the level 1 till the common iliac bifurcation, level 2 up till the aortic bifurcation, and level 3 up till the origin of the IMM. So coming to the first question, can lymph node dissection be skipped? There have been numerous studies which show that preoperative imaging have a sensitivity of only 52% to detect nodal metastasis. So these micrometastatic nodal disease cannot be detected, and it has to be only ruled out by a pathological examination, showing that lymph node dissection should be done. Nodal status also serves as a very important prognostic factor. It is predictive of a poor outcome. It may also have some therapeutic benefit in that patients with positive nodes could be given some adjuvant chemotherapy. And there is also limited evidence from some retrospective studies that EPIL-ND prolongs the survival in node negative as well as a subset of node positive patients. The guidelines are also correlating with this. EAU and AUA both agree that pelvic lymph node dissection should be an integral part of radical cystectomy. Earlier, we used to avoid pelvic lymph node dissection in patients with high risk MIBC and very high risk patients. But in them also recent data is showing that 20% upstage to muscle invasive disease. And so a standard pelvic lymph node dissection should be done in them. The only condition where PLND can be avoided is doing a palliative RC in a setting of intractable bleeding or pain. Now, what is defined as an adequate pelvic lymph node dissection? This is shrouded in controversy. Whether we should focus on the number of lymph nodes, the lymph node density, meaning how much positive nodes are there out of the total harvested, and the various anatomical template. That is the question. So studies have shown that the lymph node drainage of the bladder mostly occurs to the external iliac node, around 30%. Then the internal iliacs, 26%, obturator fossa, 25%, with 15% going to the common iliac region and 4% in the para-aortic and paracaval region. Lesner et al. And Her et al. Have shown that cutoff of 15 nodes is there, which predicts the prognosis. And the odds of finding a nodal mets are increased when at least 15 nodes are removed. 80% of all node positive patients are detected when at least 20 nodes were removed. It also improves the 5-year overall survival and the 5-year tumor-free survival, even in node negative and node positive patients. Our own study from TMH, focusing on the lymph node density, which actually means the ratio of total number of metastatic nodes to the nodes harvested. This was a retrospective analysis of 503 patients who underwent pelvic node dissection from 2006 to 2019. So we found that a cutoff of 15% was significant, meaning that lymph node density less than 15% was associated with a good survival, 5-year mean survival of around 76%. But if the lymph node density crossed the 15% landmark, then it fell down from 76% to 7.7%. Still, there is level 1 evidence is lacking with the lymph node count and lymph node density. These are considered as surrogate markers of adequate lymph node dissection. Coming to the different anatomical templates that have been defined, these have been defined as late as 2017 by the European Association of Urology clinical group. The limited lymph node dissection being the external iliac and the obturator nodes bilaterally. The standard, including the internal iliac and the bifurcation of common iliac, extending up to the aortic bifurcation, super extended, including the inferior mesenteric artery. Comparison between a limited and extended PLND. This was a retrospective study done by Dhar et al., in which they compared 336 patients who underwent PLND at Cleveland Clinic versus 322 at Bern, Switzerland. The Cleveland Clinic patients had undergone a limited dissection, that is including only the external iliac and the obturator, while the Bern patients had underwent the extended template, including the common iliac. All were node negative and none had received neoadjuvant chemotherapy. So they found that the recurrence-free survival and overall survival was better in the Bern category of patients who underwent the extended template of dissection, typically in T3 disease. And although having a higher median age of patients, these patients showed a better survival. In Bern series, 1 out of 4 patients had positive nodes, but they showed a 34% survival till 5 years. While in the Cleveland Clinic, only 1 in 10 had a positive node, but only 7% survived till 5 years. So this retrospective data showed us that probably EPLND is the proper template which gives a more accurate staging and improved survival of patients with non-organ confined bladder cancer. Then there were studies comparing the extended template with the super extended template. This study by the Zender et al. Done at the University of South Carolina, they compared the super extended template with the Bern template, that was the extended lymphadenectomy. And they found that there was no difference in the recurrence-free survival and overall survival in these patients. So the survival with extended lymph node dissection was the same as with super extended. And the super extended were associated with additional comorbidities like increased operational time, blood loss, and development of post-op complications like lymphocele. So super extended PLND, it has no proven benefit. While doing the dissection, if we find the common iliac nodes, which are hard on palpation, should we send them from frozen and do a super extended dissection? This is an unanswered question. It may vary from case to case basis, but there is no evidence to support this. Should a grossly visible node be resected above the aortic bifurcation? Ideally, yes, in a high volume institute. But again, if these nodes come out to be positive, our intent would change from curative to palliative. So there was a systematic review which was done of all these retrospective studies. They were not able to do a meta-analysis because of the poor quality of evidence and data. But they did found that some amount of pelvic lymph node dissection is better than not doing a lymph node dissection. Extended PLND, maybe it increases the survival. Super extended has no extra benefit. An ongoing RCT should be done to clear this doubt. Now, the problem with this systematic review was that the template of lymph node dissection was not determined from before, and the nomenclature of the limited, standard, and extended template was not followed by the surgeons. There was no data maintained whether neoadjuvant chemotherapy or adjuvant chemotherapy was given in these patients or not. So that is why this data is flawed and we cannot rely on it. So are there any randomized trials to help us with our thought? The LEA trial, this was done in 2016 in Germany, and this was the first randomized phase 3 trial which assessed the extent of lymph node dissection in bladder cancer. and it compared the standard template with the extended template. But in this also, in some of the extended template, the dissection was done up till the IMA, which is the super extended template. And surprisingly, this study showed that the 5-year recurrence-free survival, cancer-specific survival, and the overall survival, there was no difference between the standard and the extended pelvic lymph node dissection. But there are many flaws with this first RCT. First thing was that it aimed to show a difference of 15% between the super extended and the extended template. And around 14% of the patients had a T1 disease, which are associated with a very low risk of lymph node mets. This may have diluted the results of the study. The limited group, that is the standard lymph node dissection group, had a median of 19 lymph nodes removed, which is quite high and quite close to the extended template. So this may have diluted the difference between the two groups. Around 8 to 9% margin positivity was found in both the standard and the extended PLND groups, raising a question about the quality of the radical cystectomy and the quality of lymph node dissection. Another thing was none of these patients had received a neoadjuvant chemotherapy, and their sending for adjuvant chemotherapy depended on the discretion of the treating physician. So the issue whether extended lymph node dissection would result in a survival advantage and outweigh the potential harms like lymphocyte blood loss, this is still uncertain. And so it is also reflected in the current guidelines. So this is the up and coming player, the SWOG 1011 trial, which is conducted by Canada and US. In this, the drawbacks of the previous RCT have been taken care of by excluding the T1 group and including around 50% of the patients in with neoadjuvant chemotherapy has been given. And they have also decreased the effect size to 10%. This trial has now stopped recruiting, and recently they had published their data in an oral abstract session at ASCO 23 meet. Surprisingly, they also have found that there is no difference in the disease-free survival and overall survival between the extended and the standard lymph node arms. However, they did find that the lymph nodes which were extracted were higher in the extended group. There was no difference in the node metastasis, and the EPLNT group was associated with increased grade 3 and grade 4 adverse effects. But the difference in survival was not there. So again, with these retrospective studies, people had started doing the extended pelvic lymph node dissection, but with the result of this trial, this would soon be published in few months. Again, probably the norm would shift to doing a standard pelvic lymph node dissection only. That is up till the bifurcation of the common iliac. Guidelines up to 23, there is no conclusive evidence as per the EAU guidelines for the optimal extent. NCCN, however, did suggest that based on the retrospective data, lymph node dissection should include the common iliac nodes also. But now things will change in the coming year. Coming to the final question, does the surgical approach matter, robotic versus open versus lap? So there was a retrospective study done by Arora et al., which showed that robotic dissection gives a higher lymph node yield, significantly better compared to laparoscopic, but it is equal to open. As seen in the RAZOR and the CORAL trials, they compared the open and robotic radical cystectomy randomized control trials. So on the whole, we have found that the lymph node yield is equal in open and robotic surgeries, but overall it is higher than the laparoscopic surgeries. Now, coming to whether lymph node yield we should consider lymph node density or the anatomical template. What the take-home message is that there should be a meticulous clearance of the anatomical template rather than focusing on the lymph node yield and the lymph node density. The skeletonization of the vessel should be done properly, and that is more important. There has also been a low of pelvic lymph node dissection in partial cystectomy patients in MIBC who have underwent a tetramodal bladder preservation therapy. It has also increased the 5-year survival. So the final take-home message would be when to perform PLND in all settings except in the palliative setting. How much to perform? As per the SWOG 1011 trial, a meticulously performed standard lymph node dissection would be the current standard, which would include the external iliac nodes, the internal iliac nodes, and the obturator nodes. Uh, Whether the common iliac nodes are removed or not, that would depend upon the crossing of the ureter. Definitely, the lymph nodes above the crossing of ureter are not to be removed, and also the presacral, they will come with the bladder specimen only. How to remove? Open and robotic techniques are equal as compared to laparoscopy. So, what are the lacunae? The teaching technique is not standard in all the institute. In a low volume institute and intermediate volume institute, it needs to be standardized, the technique of lymph node dissection and the template. The effect of neoadjuvant chemotherapy on the nodal micrometastasis is not known. It is also not known whether few suspicious RP nodes which have responded to NACT, would they change the template of lymph node dissection during surgery? And the other lacunae is the bladder adjuvant radiotherapy giving in node positive patients post surgery, whether they contribute in improving the quality of life and survival. So a big thanks from the urology DMG at TMH. Thank you.
Thank you. I will request Dr. Sham to give his comments about the present practice which we do for the lymph node dissection in municipal.
First of all, I congratulate Dr. Ankit for a nice presentation. I think he has covered all the aspects of lymph node dissection very comprehensively. For our institute, our radical system, we are doing extended lymph node dissection. We are actually going up to the common iliac artery, and we'll